So if we can get the next panel up. And again, I'd like to start this with some comments from Isabel, who was the patient representative on this working group. Isabel, do you want, as we're setting up the slides, to give us a few perspectives from patient point of view? And then Dr. Maurer will take us through the cardiac working group presentation.
Yes, hi, thank you, Sarah. Yeah, I think in particular for patients with cardiac amyloidosis, this is an absolutely devastating disease. We know that delays in diagnosis and treatment likely contribute to the poor life expectancy of patients with cardiac amyloidosis. From symptomatically, their patients experience shortness of breath, fatigue, autonomic neuropathy, and edema. And while AL amyloidosis and the current treatments both significantly and broadly impact health-related quality of life, treatment has a major impact on quality of life because the rigorous therapeutic regimens are really difficult for patients to tolerate. And then even if the plasma cell abnormality is controlled, cardiac damage may be slow to improve or irreversible, leaving patients with severely impacted and compromised lives. And I think that's added to the burden is the challenge of dealing with the plasma cell abnormality and toxicities of treatment, and frustration as their quality of life does not improve even while the disease is brought under control. Given the lethality of cardiac amyloidosis, there is a huge unmet need in this area. Therapeutic options are needed desperately. And also being able to rapidly distinguish the effect of therapies is really important for patients. So with that, I'll hand back.
Dr. Maurer.
So thanks, everyone. If someone could just enable my screen share so I can show my slides, that'd be great. Thanks. Hopefully everyone now can see my slides.
Yep.
Good. So I wanted to thank ARC and the FDA for organizing this and galvanizing our group together, and remind everyone that we do this to advance the care of patients. And I've had the privilege of spearheading a working group that's delineated here of esteemed colleagues throughout the world, representing major amyloid centers, as well as regulatory colleagues, and those from industry and from statistics, and from Isabella, who's spearheaded our efforts. Our group, working group, considered a long list of cardiovascular endpoints, which are highlighted in this particular slide, including obviously mortality, hospitalizations, and the combination of those into novel surrogates that are reflective of the patient journey, days alive out of hospital and home days. We considered extensively biomarkers shown here, as well as some emerging endpoints that are similar to what is, I think, used in oncology, highlighting a cardiac deterioration, progression-free survival. As cardiologists, obviously, we focused a little bit on imaging endpoints, and we'll give you our feedback about those, as well as functional measures and quality of life. And these were the ones, again, that were considered. We prioritized these 6 endpoints after extensive discussions. And in the ensuing slides, I'll go through each of these prioritized endpoints and try to highlight some of the data that brought us to our conclusions and some questions that we still have. So we'll start with obviously mortality, either all-cause or CV related. And each of the subsequent slides for each of the 6 considered endpoints will follow this paradigm, looking at whether it's objective, is there meaningful thresholds, is there clinical relevance, a natural history, a timeline and horizon, and some open questions. So obviously mortality is an objective endpoint. It was one that the group obviously endorsed, but we're hopeful that we could design approaches that will accelerate the development of drugs and not rely specifically on mortality alone. There was a general agreement that a 15% relative risk reduction in mortality, given this devastating condition, would be clinically meaningful. As all, I think, appreciate, cardiac mortality in AL amyloid is exceedingly high and thus very relevant, well-recognized endpoint by regulators. But as we mentioned, could bias trials and delay them if we really only rely on mortality. Many centers, both single and multi-center studies, have shown that cardiovascular mortality is high, and it's based on stage of disease, whether you had a hematological response, and there have been developments of cardiac response criteria that are quite effective and used clinically. I think it's less well defined whether there's the mortality issues in long term and whether cardiovascular death, thankfully, after people survive the first few years of AL amyloid treatment, is a main driver of outcomes. And obviously, the stage of disease is an important determinant of one's survival. And certainly, the rapidity of one's hematological response and its extent, as my colleagues were highlighting just previously, is an incredibly important determinant of outcomes in this particular population. So I think we're all aware of curves like this, in which we see obviously improvements in mortality over time, but very high early short-term mortality that's mainly mediated by, as shown here, cardiac death. And so this is further evidence of the fact that mortality is an important and relevant endpoint in consideration in AL amyloid trials. And all of us have seen the evolution over time of the biomarker staging systems that have highly correlated with long-term survival, using obviously NT-proBNP and troponin, along with the difference in free light chains, and BNP as well, and modified criteria that better stage more advanced patients for our European colleagues. And so I think the open questions in the realm of mortality as an endpoint is, should we be using overall or CV related? We heard from our regulatory colleagues that certainly if CV is the main driver, they would prefer that to be the defined endpoint. Rarely do they want a therapy that's going to be tested on overall mortality unless it's important to choose that. Obviously, there's this emergence we could talk about of restricted mean survival times compared with traditional metrics that may better communicate the impact of a particular therapy. There was a lot of discussion about whether the cause of death needed to be adjudicated by a committee or investigator determination would be sufficient. We've seen that in other heart failure trials in general, where that added cost may not be necessary, because certainly the clinicians are the ones at the bedside caring for the patients and are best able to determine the cause of death. And we'll talk in a little while about the concept of the patient journey and can we use other metrics like home days or days alive out of hospital. So endpoint number 2 that was considered was hospitalizations. And again, it's clearly an objective endpoint, but one that was not endorsed for several reasons. While we did reach agreement that about a 20% relative risk reduction in hospitalizations we thought would be clinically meaningful, and the patient-centered goals of days alive out of hospital, or the concept of home days that not only includes days alive out of the hospital, but days that are not in a rehab facility or an institution, are important to consider, though, as you'll see, there really aren't data at present to really derive thresholds for those to be utilized as, I think, meaningful endpoints. Certainly hospitalizations we recognize as highly relevant and well recognized by regulators, certainly in heart failure trials, which led to its prominence in our considerations. The natural history, unfortunately, despite having large data sets, is not very well delineated in large multi-center trials. Many of us are not recording who's hospitalized. Patients travel to remote centers. And there's really little data on whether the hospitalization is due to cardiovascular related or non-cardiovascular, or whether it's related, God forbid, to the toxicity of our therapies. Certainly hospitalizations tend to be frequent and tend to cluster. And so would repeated events be more important in the statistical analysis and better reflect the patient journey? And as I mentioned, probably similar to mortality, hospitalizations are going to be highly dependent upon the stage of the disease, and often, unfortunately, precede morbid events. Certainly, we're not sure how to account actually for hospitalizations related to our therapies versus those related to the underlying disease. We weren't sure whether or not international studies with different rates in the hospitalizations and different lengths of stay would impact certainly on this outcome in international trials. And we wondered whether or not claims data could be leveraged to delineate and give us more data on their frequency. This continued interest in a more patient-centered outcome, that is days alive out of hospital or home days, was a persistent focus of our group. I would note these are some preliminary data that we accrued in our center, just highlighting some of the complexities of days alive out of hospital, obviously at various time periods. I think you can see the percent here of the time people thankfully spend alive or out of the hospital. It declines significantly. And because AL is much more morbid than TTR, there's a lower days alive out of hospital. Having said all that, you can see that there's a hugely wide variance and making us concerned, I think, as a group, whether or not this metric would be exceedingly useful, at least at this point. I think we spent most of our time, however, focusing on what we think to be one of the most important emerging biomarkers. We believe NT-proBNP is the cardiac biomarker that is best positioned of the ones that have been studied to date as an endpoint currently. And many felt on the group that it could be considered as a surrogate for survival in light chain amyloidosis, in particular, obviously in response to anti-plasma cell therapy, given the biological plausibility and the light chain toxicity that we see. There are well-validated criteria that colleagues have promulgated, delineating a response shown here of a 30% decline and a greater than 300 decline of nanograms per liter, assuming there's a baseline value of at least 650, and there are progression criteria as well. And there are even emerging graded criteria that, similar to the hematological response, tend to grade the NT-proBNP response. All of us clinically are using this to guide management currently and assess patients' response to therapy. And there is a strong data, I would say, associated with survival, both in retrospective and now in prospective data sets. As we all know, we can't, as cardiologists, achieve a cardiac response unless there is a hematologic response in this particular disease. And so the kinetics are pretty well defined. And the relevant time horizons are meaningful here because it can be seen relatively early in the course of the condition. So just to highlight, certainly in light chain amyloidosis, the light chains are toxic to cardiomyocytes, and so there's a really tight link between the production of light chains and the toxicity to the cardiomyocyte. These cardiomyocytes in the setting of light chains activate the MAP kinase signaling pathway, which induces a transcriptional upregulation of the BNP gene. And thus in AL, the levels of the natriuretic peptides really reflect the insult by the light chain species to the cardiac and cardiomyocytes. As I mentioned, they don't really decline that as biomarkers unless the light chains come down. And that's really in contrast, I would say, here in the general world of heart failure, which I also live in which in non-amyloid heart failure, there are multiple mechanisms, including but not limited to mechanical strain, neurohormonal factors, extracardiac conditions, and altered clearance that really contribute to the natriuretic peptide response. So seminal data that's been collected by colleagues and that was highlighted have shown obviously the importance of a hematological response with regards to outcomes, and obviously shown here with regards to cardiac response criteria and improvements or, God forbid, increases in mortality of using various parameters. I would note, obviously, our old use of wall thickness doesn't work very well. Ejection fraction also works okay, but takes a little time for the curves to diverge. It's not an early marker. But certainly NT-proBNP, both at 3 and 6 months, allows us to identify patients who are responding to a particular therapy. We've noted, as shown here in this figure, that the time from initial treatment to a first documented response, this is in any organ, but including cardiac. And as you can see, often occurs very early. In specific cardiac involvement, response rates are pretty high using the NT-proBNP criteria and tend to occur pretty early, certainly after a normal free light chain ratio. And you can see in this curve here at the bottom is among the subpopulation who obtained an organ response following therapy, the time frame of a first documented organ response is shown in relationship essentially to time zero here, where we get a normal free light chain. And most responses, as you can see, are seen within 6 or 12 months. Additional data, I think retrospectively from these series has clearly shown using these criteria that there's a huge difference in survival in those who have an NT-proBNP response versus non-responders. And now we even have prospective data from clinical trials and registries conducted that show that those who have a NT-proBNP response have a markedly better survival than those who do not, and same for NT-proBNP progression. So this was the biomarker I would say that we endorsed the most, and I would note that we did have some residual questions, how to reduce variability, again, maybe by repeated measures or as people have done to find landmark times at 3 or 6 months, or possibly using the slope of the change. And how could we better present these data maybe to regulators, because we think they're robust, in order to potentially think about NT-proBNP as a true surrogate in AL amyloid, at least in response to anti-plasma cell therapy. We spent time talking about the 6-minute hall walk test that is, again, well recognized by regulators, especially recognized in cardiopulmonary disorders, and is, we think, objective and standardized, but probably subject to bias in open label studies. It's familiar to cardiologists, but less often to hematologists. And as I'll show you in a moment, baseline data using a cut point of 300 is independent in the Mayo stage for predicting survival. It strongly correlates with other performance measures that are used in oncology and in cardiology. And there is impressive single center data from the National Amyloid Center showing improvement at 12 months, really only in those in the 6-minute hall walk who achieve a hematological CR. And that a 33 meter was an important improvement, was independent of the hematological response, suggesting it could have important value. Also, if you can't perform a 6-minute hall walk, it has an extremely poor prognostic prediction for the patient. And it does deteriorate at 6 months, and so probably requires a little bit longer time period than we've seen with the biomarkers to be utilized as a landmark. And so I'll highlight these data again from the NAC, in which you can see the overall survival in a large cohort of people, many of whom had cardiac involvement. Those unable to do the 6-minute hall walk had a median survival of 5 months. Under 300 meters was 25 months, and greater than 300 meters was not reached. And as I mentioned, the hematological response always predictive, and the 6-minute hall walk in particular, an improvement at a year on 33 meters had a residual statistically significant hazard ratio, suggesting this could have important value. We struggled with how we could better integrate this into clinical practices, and how we could better validate it in multi-center studies. Can it be done remotely? There's a lot of interest in actigraphy, but the feeling of the group was that at least actigraphy has a lot of variance, and at least is not ready for prime time. And there were other measures that were talked about, like the short physical performance battery, which seem to have promise because they include measures of frailty and gait and balance, but have not yet been studied in amyloid. KCCQ was the quality of life endpoint we thought most useful from the cardiac group, and I won't spend much time on it because we have a group focused on quality of life parameters. It's certainly objective and standardized, but it's certainly subject to bias in open label studies. There are known thresholds that have been promulgated, and a 5-point change has been considered in heart failure the minimally important difference. It's a recognized measure in heart failure, performs very well, as we've seen in the ATTR-ACT trial. And unfortunately, however, data in AL amyloid is limited, and there's data associated that those who have a cardiac response do better on the KCCQ. The natural history is not well delineated because we don't have longitudinal data, and we don't know the time horizons for AL amyloid. Based on ATTR, it could be as early as 6 months. There was a lot of discussion about whether SF36, which is a more general measure, would be valuable in this multisystemic disease. And obviously, how useful is the KCCQ, and does it perform in patients who don't have cardiac involvement in AL amyloid? That would be a major limitation. And again, back to accruing more information and data, but this wasn't felt to be, at this point, one of our highest parameters ready for prime time. People have mentioned this concept previously that was operationalized, I'd say, in the Andromeda trial, major organ progression-free survival. And we thought it was an objective threshold, but is not yet widely accepted. And the Andromeda trials seem to use a pretty, we thought, limited and morbid events related to transplant, needing a VAD or a balloon pump, obviously back to death, but the cardiac deterioration. And so we were somewhat concerned that these are relatively infrequent events and might miss patients. The group tended to favor essentially, potentially the idea of, again, leveraging biomarkers and their validity and progression to define cardiac progression criteria. We believe, are still clinically relevant, as obviously, unfortunately, cardiac disease and its involvement is the primary determinant of early survival in these patients. And we do not know the natural history of this parameter. And obviously, organ responses still lag behind the hematological response. So this could take predominance in a multi-system hierarchical model. Again, can these proposed criteria be validated in future clinical trials? And does the response in other organs correlate? Do they add anything prognostically on top of the cardiac response, especially when we start to make measurements of many things? So just some data that we thought was important to highlight. This is a publication in which of 215 patients evaluatable for a cardiac response, there were 182 patients who achieved an NT-proBNP cardiac response, and the median time you can see was from initiation of treatment was about 9.4 months. The median time to a maximum cardiac response was 24 months, and this was the nadir and the maximum reduction that was seen. And as I mentioned, there's a grading system that uses depth of the cardiac response and is highly associated with prognosis. We would note that these are prospective data, again, from the clinical trial noted here, in which there's a marked separation of the curves prospectively when we're looking in the context of therapies that are anti-plasma cell on those who progress with those who don't progress. And so maybe the progression criteria could, again, we believe, rely on biomarkers. The working group discussed the utility at a very high level of various endpoints kind of at the stage of the disease. And these are represented very granular, or I should, very high level in this slide. In brief, obviously, since mortality and hospitalizations are thankfully not very common in early stage disease, we thought they'd be more useful in more advanced stage of patients. Biomarkers, again, NT-proBNP was noticed to be useful really across the spectrum of disease. Data on the 6-minute hall walk and the KCCQ are limited, as I mentioned, but there was a sense of the working group that they would be most useful as endpoints for kind of intermediate or later stage patients. And again, cardiac progression-free survival was limited with regard to data, and thus the working group didn't really have any experience knowing which stage it would be useful for. And finally, we often emphasized in our discussions that the endpoints discussed in the available data, at least to date, are really in the context of anti-plasma cell therapy, not anti-amyloid therapies. And this presents, obviously, somewhat of a dilemma. Finally, it would be remiss not to touch upon our discussions about imaging endpoints, which we did discuss extensively, in particular strain and extracellular volume. These were felt currently not to be ready as surrogates for phase 3 registration trials, but we strongly encourage their use in all studies because they could provide a lot of mechanistic import, both in phase 2 and phase 3. A global longitudinal strain that's obtained from echo is a strong prognostic marker. The group felt it was more likely to be useful in assessing anti-plasma cell therapy given the underlying light chain toxicity. But we would note it has a poor signal to noise ratio. There's a lot of variability, and it would take, again, 6 to 12 months to show an effect. And so we weren't sure about the utility to get an early signal. The agreement was that about a 1.5 to 2% absolute change would constitute potentially the minimally important difference. An extracellular volume is obtained by MRI. It's likely to be more useful, people thought, in our working group in anti-amyloid therapy, showing the removal of amyloid. There's significant challenges, however, because there are different vendor platforms that we use and different magnet strengths, different acquisition techniques, and harmonizing all of those across sites would be challenging. The group did endorse, though, that a 5% absolute difference from the emerging literature would be probably clinically important. And so I'm happy to open it up to questions and thoughts from any of my panelist members.
Okay, hello. Thanks, Matt, for this great overview. So we will start the question and answer session now. There are quite a few very relevant questions. And let me see what we have here. Okay. So I have a question from Vaishali, if we want to start with that.
Yeah.
Please, Vaishali.
Yes, so I can ask the question. Matt, how did you choose the overall cardiovascular mortality to reduce by 15% or 10%? Why not 20%? Why not 5%? So how did you get to that number? Was it just, kind of consensus of all the members of the group?
I'll comment and say I think that it was a general consensus. Obviously, we're dealing with a condition that's highly morbid and life-threatening. An incremental improvement people felt in mortality that was of that range would constitute some therapy that they, as a clinician, would be interested in providing to patients. And sometimes I think the concern was if we set the bar too high, more traditional metrics, 25, 30, or 35%, we could end up missing clinically important therapy. So,
but for the cardiovascular hospitalization, then you chose 25%.
Correct. It was a general consensus that that needed to be a little bit higher bar to be reached. But since mortality is obviously clinically more significant, but I don't know if colleagues, John Paulo or others want to comment, or Mariana.
Yes, Vaishali. I agree that this was a consensus, but obviously all these should be validated. I agree that we need just to propose for validation certain point, but obviously consensus is not enough.
Thank you.
Yes, agree. I think, yeah, consensus is definitely not enough. Yeah.
Are there any other comments on this question? So we can move forward. And actually, I have Shaji Kumar with 2 questions. So perhaps one is actually related to what has been just asked about the cardiovascular and non-cardiovascular mortality. But Shaji, if you want to go ahead with your question, and perhaps then we can move to the next topic and discuss a bit more about biomarkers, as there are a few questions about that.
Sure. Yeah. No, I think the question, I know you stressed on the cardiovascular mortality versus overall mortality, and it becomes really hard to sometimes distinguish between those. And I think you alluded to that already in terms of independent verification. But I think it's especially in the multi-organ, with multi-organ involvement, I feel like there has to be, you probably be better off just looking at overall mortality, right? It's going to be really hard. I don't know what the experience has been in the cardiovascular disease trials. Probably a little bit easier because they are single organ issues often, but in amyloid, that may be a very difficult thing to do.
I'll give you my feedback. I would be interested in hearing Preston's as a regulator, but we struggle with this a little bit. Obviously, as you're pointing out, in early phase disease, cardiovascular mortality is a main driver. And my recollection of the feedback from regulators was, say you brought a therapy to bear that, your data set, and it seemed to have a dramatic effect, appropriately, hopefully, on mortality, but it was mainly driven by cardiovascular. The regulators would probably end up providing you with a approval based on cardiovascular, because that was what mainly drove the endpoint. But I agree, it's important, obviously. I don't think any study that's embarked upon wouldn't try to obviously look at overall mortality in some way, whether that's the primary endpoint or not. It's, I think, dependent upon the group you're recruiting, what the therapy is, and so forth. Preston, you had some thoughts about this, I think.
Sure, and thanks for that, Matt. When you look at heart failure trials in general, outside of the amyloidosis space, what you find is that the CV mortality is overwhelmingly driving the overall mortality result. And so we don't tend to issue claims for decreasing all-cause mortality, because that implies somehow that, for instance, that this therapy might decrease traumatic fatalities, which obviously it wouldn't do that. I can see that, I think we have to be a bit pragmatic here on a couple of levels. I'd point out that there are some therapies that we have reviewed recently that decrease heart failure mortality by a smaller number than 20%, but are very safe. And patients who get the choice of something, of a lifelong therapy that decreases their mortality by 10 or 15%, as opposed to the 25 to 40% we see with the things that really impact this, they're still interested if the safety data on the drug, it looks really good, and there's not a high price to pay for that small increment. So in this space where there are competing risks going on, you might have a therapy that could be potentially quite toxic in some ways, but for those who respond, may have a very good cardiac response. For instance, this is just a scenario, and I'm thinking here about possibilities for anti-amyloid therapy in particular. In those scenarios, I think arguments for looking at all-cause mortality could be made if there are competing toxicities going on, and what you've got to do is figure out, is what you're doing positive for the heart overdriving a negative effect, say, on your liver. And we can't ignore that when there are competing risks going on. So I think that an argument for all-cause mortality could be made on a situation-specific basis, understanding that we have not done that to this point, just because in the big heart failure trials, that's never been an issue. CV mortality has overwhelmingly driven the result. Oh, one other comment I'd like to make here, Matt, on this issue of adjudication and cause-specific determination of mortality. I'm not aware of any data that we've seen that suggests that that adjudication changes interpretation in the end of what we think in heart failure efficacy to date. I've reviewed a lot of these kind of things, and what it strikes me is that I'm always a little uncomfortable with the premise that adjudication essentially ends up throwing out data, and that's never necessarily a good thing. And then throwing out data based on somebody's opinion who wasn't there. And so we continue to be open to sponsors directing those assets and resources to, say, enrolling more patients, as opposed to carving out those assets for this process that may not change in the end what the decision is, and decisions being made by people who are not at the bedside taking care of the patient.
Other questions, Christina?
Yes, actually, I was going to ask Brandon if these partly address your question about the non-cardiovascular reasons for these patients, like autonomic dysfunction, malabsorption, etc. Do you have any comment on that, Brandon?
I think you got it.
I think it does partly address the question, and I'm glad you brought up the issue of adjudication, because the challenge in amyloidosis is, you know, it's overwhelmingly the patients are having, you know, experiencing adverse events and death from cardiovascular disease. And I'd love to hear, you know, from Matt and Mariana and others on the panel, is it even possible to attribute these events to anything other than the disease? It seems very challenging to me. So especially if you're an adjudication committee looking at source documents, you know, months later. So I think we do have to rely on the investigator.
Yeah, I would in general endorse that. I would tell you, obviously there are different diseases, AL and TTR, but I, as the chair of the ATTR ACT committee, was very worried about people adjudicating and what they would, but again, different disorder. It wasn't hard at all for the adjudication committee in hindsight, and it was obviously mainly cardiac. I still think in AL, certainly early on, the main driver of survival is the heart. So I think sometimes we think it's more complicated, but may not be for people who have some expertise in looking at these things. They do a pretty good job, is my sense overall.
But to Preston's point, does it add value or ever change dramatically? I think is a very interesting one. Thank you.
Perhaps I can add something to that, if I may. It's Krishna. Apologies, my camera isn't functioning very well, so I don't want to interfere with the sound. I would agree with the observations made so far about adjudication and adding value to the overall dimension. The adjudication would be useful if there is a lack of clarity on the cause of death, and trying to subgroup or subclassify cardiac death, it might be useful. But in the overall context, adjudication, I haven't seen, as Preston has commented, that I haven't seen any evidence that adjudication improves the overall outcome in any form this far, having seen these over the last 20 years or so for various heart failure trials. So I would be in favor of not having a mandated adjudication system. I am aware that I'm speaking slightly out of context and from my European colleagues who prefer adjudications for mortality, but having gained the experience over the years, I'm inclined to think that the physician's observations would be as valuable as an adjudication committee. The second comment I wanted to add was the distinction between cardiovascular mortality and all-cause mortality. Again, the European preference has always, regulatory preference has always been for all-cause mortality as an overall context, the concept. However, in this context where we know that the disease is multi-system, a significant change in the cardiovascular mortality and which overwhelmingly influences the outcome, if any, would be sufficient. It is a difficult distinction to make, but either or will work. And we, as a regulator, I would be personally satisfied with CV mortality as an endpoint. Thank you.
Thanks.
Okay, I think we can move to a few questions about NT-proBNP cardiac biomarkers. So I have one question from Shahi, if you want to address it, and perhaps to have Spencer to comment on that and, I mean, bring his questions to the panel. Saji?
I'm sure you discussed this, but the transient worsening of NT-proBNP is going to be one consideration. And we see that especially in some drug classes, and that needs to be taken into consideration. And the second is how do we deal with the situation where the renal function may have slightly deteriorated, but you still may have a cardiac improvement or not necessarily worsening based on that NT-proBNP.
I'll give you my answer. I think this is a good question for Gianpaolo, but it works, guys. I mean, it works even in that context. I mean, I think sometimes we get involved in the nuances, but when patients are getting better clinically, their hearts are getting better and their kidneys are getting better. And the studies that have been done certainly have included people with AL amyloid and multi-system disease. And despite, you know, concerns about variability and concerns about what might happen in the setting of worsening renal function, at least the data that we reviewed strongly suggests, I think the group came to consensus that it's incredibly valuable. But Gianpaolo, you spent all your time collecting this information. So.
Yeah, I agree, Shaji, that exceptions will also be present, but this is true with any marker. So I think that it is very important to keep in mind that it is working in the vast majority of patients. In patients with severe renal dysfunction, of course, you can use BNP, that is more reliable. So that may compensate. But overall, NT-proBNP is by far the most solid biomarker that has been tested in several contexts that we have nowadays. There are questions about other possible biomarkers, and I agree, but they all need validation. Just to respond to the good question by Joel Bushbaum. Well, we need to validate them.
It'll be important to just put some guardrails around those transient worsening, right? Otherwise, you'll see patients going off trial, but just based on that, when we know that's going to come back down.
Yeah, I think you're very right. There are certainly, as you know, certain classes we see where there's but we again think for a majority of patients, this is certainly something that's nearly ready for prime time.
And Gianpaolo, Matt, Mariana, what is your view about the type of mechanism of action of treatments when we refer to these biomarkers? So should we consider any different approach, or same definitions for cardiac response in this case? And there is also a question from Spencer about this topic. When we have, for example, plasma cell dyscrasia treatment versus amyloid-directed treatments.
Yeah. May I start first?
Please.
Please.
Okay, I think that we do have few data on anti-amyloid biomarkers. So in the anti-amyloid therapy context. So I believe that it is difficult to draw a conclusion. We have encouraging data from the Kaelum 101 trial, and NT-proBNP there goes very well together with the strain improvement. So indicating that it isn't indeed working very nicely. But we need to have more data in order to make sure that NT-proBNP is working. I mean, all the rationale would imply that it will work also in anti-amyloid therapy, because basically, if you remove amyloid, you reduce the stress on cardiomyocytes. But we need more data in order to determine this. Mariana, what do you think?
Yeah, I completely agree in the sense that we need more data, like to be able to transition to blood biomarkers when we think about different drugs with different mechanisms. And I think that exactly here is the role, for example, for more specific imaging biomarkers, because mechanistic studies that prove the specific pathway can then let us to understand how then we can use extremely simple blood biomarkers that then could become the surrogate markers of the specific pathway. So, and this is this is really where I think that each of these biomarkers has got a different role. And ultimately, what the ideal situation is when we understood it so well at all different levels that actually with the blood samples, we can do everything. But to get there, still small mechanistic studies with imaging biomarkers will be extremely powerful to basically fill the gap, increase the knowledge, and being able to transition.
Yeah.
And to this point, if I can add this, and to the point that Matt was making in his presentation, I think that we have to encourage really the use of this imaging, like cardiac MRI, for example, but also echo in larger trials as well, because I completely agree that we have to understand more and correlate more, but then in the end, we always find it problematic when we don't have enough patients in these studies, right? So we understand the mechanism, but then we have to apply this to the larger population to understand more and to make this correlation that you, Mariana, suggest that are really important, to go back to the simple stuff, so the biomarkers that we perhaps can measure in the blood.
Yeah.
We're rapidly approaching a need to move to the next session. So are there any final urgent questions? And then I might pass to Matt to do a bit of a summary on what we've heard.
Just very briefly, Mariana and Christina, from a lowly cardiologist here that doesn't do hematology, if you have an anti-cancer drug that, like in breast cancer, the and the anthracyclines, for instance, that could give you a quote CR, in that cancer, in this case, multiple myeloma, but has important cardiac toxicities. And some of these drugs have toxicities very early. Is that kind of what you're getting at here as far as looking at say, biomarker responses to different mechanistic classes to see how that's shaking out? Because I could see where you might get more cardiac adverse events with a particular agent that is directly cardiotoxic early that gives you a complete CR with the hematologic response.
Yes, I actually think that when we think about, for example, breast cancer and anthracycline, I think NT-proBNP and troponin are phenomenal. In the sense, these are healthy patients with normal NT-proBNP, and actually, when you measure it 48 hours after the dose and it's increased, then you need to follow them more closely. And then it's where imaging then have a role. In the sense, I think the role of imaging, I think is almost reversed, in the sense NT-proBNP as a screening tool and then imaging to see what goes on and if anything in systolic diastolic function, what happens and if it recovers. Here is almost the opposite. We've got heart that are very, very severely involved, and NT-proBNP then becomes the final common pathway of several different mechanisms, from direct myocardial damage to neurohormone activation to fluid to everything. And why is so powerful? Because it's the final common pathway of all very important mechanisms. And but is not able to dissect what actually happens when in that specific pathways where the drug is actually targeting a very specific target. And so here imaging is able to dissect the specific targets that we want to follow, instead of having a more kind of general feeling of how the patient is, that actually NT-proBNP can provide very easily. And so it's, I think, a bit reversed in these two situations. What do you think?
I completely agree, Mariana, and especially when we consider that we see certain levels of cardiac response by NT-proBNP, for instance, and we don't know what exactly is happening at that specific time point to the heart of that patient. So is it because we are getting rid of the toxic light chains, or is it because at some point the patient is also showing some regression of the amyloid in the heart? So imaging, at least some type of imaging, can also answer and help answering this question at a more pathophysiological level.
Yeah, but nevertheless, NT-proBNP summarizes the heart function in this patient.
Yes, definitely.
So it's really irrepressible, is unique in this situation. And it can be used also to screen. I mean, if you see NT-proBNP improving, you know that your patient is going to benefit if it is worsening, then you can figure out with imaging what is going on. So it is really a key biomarker.
I completely agree. And what I is not just a key biomarkers because it's cardiac, it's a key biomarkers because it tells you everything. It tells you neurohormonal activation, fluid balance, renal function. And that's why it's so powerful, because it tells you how is the patient doing. Yeah.
Unfortunately, I think we're going to have to move on, but I think we're hearing very strong support for NT-proBNP, even if we want to dissect the other pathways a little more through the imaging. And so I think one of the next steps here will be to try and have more dialogue with the regulators on NT-proBNP as a surrogate. I'm hearing very strong support for that. Matt, do you want to finish us off here?
I'd just like to thank everyone. There were 2 residual questions I'll just quickly address. We did consider other imaging. Sharmila asked about PET scans, and certainly we believe that those hold great hope. We hope other imaging approaches will be useful, but there's just no data. And people commented on 6-minute hall walk also having this heterogeneity amongst the patients who have neuropathy and so forth. And we think that would be a reason to embrace it, because it, similar to NT-proBNP, is measuring a clear sense of one's functional capacity, irrespective of what the underlying issues are. So again, grateful to everyone. It was a wonderful and robust discussion.
Super. Thank you very much indeed. Tremendous work here. So we'll move along.